Welcome to The Patient Physician, a space for doctors to explore their physical, mental, and financial wellness. Your peers and industry leaders will destigmatize institutional perceptions while redefining success, money, and personal care. Get ready to pull back the curtain because here, you are both patient and physician.
Hello and welcome to The Patient Physician. My name is Paul Smith and I'm joined today by my co-host, Chris Fulbright.
Hey, Paul. How you doing, buddy?
I am great today. I am very excited to welcome our next guest, Dr. Carol Bernstein. Welcome, Carol. How are you?
I'm fine. Thank you so much.
Thank you so much for joining us. I know that you maintain a very busy schedule. We just saw you down in Florida for the annual ACGME conference. Got to listen to you and hear you talk about such an important topic within the medical field and especially within training. It's a topic for us that's very important and we're passionate about. So we're excited to have you on to speak more directly with our audience. Before we jump in, Dr. Bernstein is professor and vice chair for faculty development and wellbeing in the Department of Psychiatry and Behavioral Science at the Montefiore Medical Center, Albert Einstein College of Medicine. She's also a senior scholar in the Department of Education and Organizational Development for the Accreditation Council for Graduate Medical Education, aka ACGME. She was previously vice chair for education and director of residency training in psychiatry at NYU and still in New York City. So again, welcome to the show. Yes. Well, you were just in Austin. We were talking about that and missed you there. I bet I haven't been to New York as many times as you were saying you've been down to Austin, but it's a fun place to be. Again, thank you so much for taking the time out to spend with us and talk to our listeners. The subject matter of well-being and specifically stigma around mental health, especially in the medical field, is such a big topic, and it's been at the forefront for many years. We know that ACGME has been such a big proponent and supporting it and trying to help the different institutions around the nation in terms of how they better prepare and train the residents and fellows. Can you just start out by giving a little bit of context and background to why I think it's going to be more intuitive that why this is such a big deal, but how it came to and when it started to really pick up steam that we really need to do something about this?
Well, this is a perfect segue for what I'm going to tell you because really most of my career until now has been involved in medical education. If you will, my passion has been making good doctors. That's what my career's been about. Even though I'm trained in psychiatry, I didn't anticipate that I was going to really get involved in medical education, but that's been what I've been doing for, 30, well, a lot of years, we'll say a lot of years. But how this got going for me was that I had the good fortune to be elected to the board of directors of the ACGME. I'm not going to say the whole name since you said it at the beginning, but I can tell you exactly in September of 2013, we had a board meeting in Chicago, and that summer, 2 interns in medicine had died by suicide in New York, one at Columbia and one at Cornell. And there were people in the room who'd been involved in this. The program director from the emergency medicine program at Cornell, where one of the residents had been brought. There had been a lot of upset here. The student, in fact, who was an intern, had graduated from NYU, so there were 3 medical centers that were profoundly affected by this. And I remember sitting there, I was the only psychiatrist in the room, and I remember looking and thinking, my goodness, if we can get doctors to look at themselves and how they're doing, we will do a much better job of having them look at the mental health issues of our patients, which has been a long-standing issue for me. I had the good fortune also to be president of the American Psychiatric Association, and advocacy around mental health was as much a part of my career as medical education was. So I will really tell you that's where the discussion began in earnest. In 2003, the AMA had looked at physician mental health and said, this is important, we should do something about it. They brought brought together a whole bunch of poobahs, leading lights in the field, but nothing happened. But what happened in 2013, for reasons that I'll go into too, was really a tipping point and a different point in time. So the ACGME, we got together, we set up a task force that I co-chaired with Tim Brigham, and we planned for a symposium that ended up being in the fall, actually, I may be off by a year, but the fall of 2015. And we brought together a bunch of people involved in GME. We decided to bring in people from the whole spectrum of medicine, from the AMA, from the AAMC, because we thought it was a conversation that everybody should have. And at the time, and I will just say this, Daryl Kirch came representing the AAMC. He was the CEO at that particular point in time. He's also a psychiatrist. I've known him for a long time. And, he said to Tom Naska and to Tim Brigham and to me and to the board, look, if we're going to really make movement on this, we have to engage the National Academy of Medicine. And he and Tom Naska went and met with Victor Zhao subsequently. And in the summer of 2016, there was a meeting at the National Academy where basically the Action Collaborative on Clinician Wellbeing and Resilience was born. That was really where it was born. But I will tell you, we started this with what had happened in New York. And then it started to take off because there were a lot of things going on in medicine that were impacting the well-being. And I'm going to distinguish that from mental health of all the people working in the field, saying, the fact that patients were being admitted for such short periods of time, the medical record epic or whatever system you use is very convoluted, was never set up for clinical care, was really set up for billing purposes and scheduling. And doctors and nurses and everybody was really more and more removed from taking care of patients. And that was causing a lot of distress. And that was all before COVID. Right? So we're already building this movement. There's a lot of momentum. It was kind of what I call Malcolm Gladwell's tipping point. And then the pandemic happened. So we were already at a point where there was a lot of distress among healthcare professionals, particularly residents, medical students, and the doctors, but also among everybody else. And then after the pandemic, it really exploded. So that's just a quick summary of how this issue came to be.
That's a lot to tackle over the years that you did it. And then to have COVID hit and have to deal with things through that, which we know pierced through all parts of society.
Correct.
In terms of mental health and any kind of wellness. I think it probably exposed it even more so. Now having gone through that and having a real emphasis on it for the past few years, would you say that it's taken the route that you were hoping for? Some of the people that you started with, is it building up more steam, less, kind of what has been planned or what's to come as well?
Very, very good questions. I mean, I think we have done a lot. I think the awareness and understanding of the significance of mental health in particular has really exploded, which is great, which is something we sort of at the APA have wanted for decades. We've been talking about this. We've been talking about this stigma and how do we engage people in getting treatment when they need it. But this has really helped in that regard, certainly in terms of education and awareness, those pieces. I'm going to put the stigma piece over here for a minute. At the same time, there has been a conflation of well-being and mental health. They are not the same thing. The causes are not the same. The fixes are not the same. And they've sort of been all mushed together. So I think we really have to try to pull that apart. And in fact, we're going to have a summit. We're calling it a summit. It's only a 4-hour thing. It's the best we can do. The APA is coming to New York in a couple of weeks, and we're going to bring together some of the leaders in psychiatry who've been working in this area specifically to talk about this well-being mental health and what our role should be. So that's really important. I think stigma has been reduced to a significant extent, but it's still a major problem in society in general, a bigger problem for older people. I think the younger generation, our residents and our students particularly, they're kind of overwhelming our mental health services. And there's a downside to that, which I can get to too. But the awareness piece is done. The fix for this, how we address it, knowing that there are not enough providers, knowing, and I feel I just have to say this, that there is insufficient insurance support for mental health conditions. And what that means is that we already don't have enough providers. And if insurance doesn't pay adequately, then people are out of network, and it's even worse. And it becomes financially extremely difficult for people to find the mental health services that they need. And that's certainly true for our house staff as well as our medical students. Now, our medical students, the AAMC has been very forward-looking about needing mental health services for students, as there are now on college campuses. The house staff are a whole different kettle of fish, in part because they have insurance, right? They're salaried, so they have insurance. So the answer of the healthcare systems where the trainees are working is use your insurance. But as I said, nobody takes insurance because the reimbursement is inadequate. So there is access that's a problem. There are a number of provider issues that are a problem. There is still stigma, okay? There's still stigma, which, relates to, I shouldn't have to do this. It's pull yourself up by the bootstraps, that kind of thing that has impacted mental health for centuries. So they have that. They don't want to dump work on their fellow residents, and they don't have time. Time is a big issue. You're in medical training. You're working 80 hours a week. I mean, when I did it, it was 120 hours. I mean, there really wasn't time to do this. And how do you carve out the time when the patients need you 24/7? So it's very complicated. And there are still concerns about licensure. What's going to happen to my license? What if anybody finds out? What about insurance? What about disability? What about credentialing? I still think we have a ways to go there, but those are just some of the current issues now.
That speaks to a lot of the pieces that you brought up during the conference when you spoke. I want to ask that specific question because you brought up 3 points at the beginning, which were the barriers. But if I can, I want to actually back up and get your description. And this is the first time I really kind of have thought this way or asked this to somebody in psychiatry or even a psychologist. So we think about physical health. That's pretty easy. Somebody gets up, they go exercise. You can really judge that. You down to cardiovascular or strength or endurance. Those things easier, probably because there's been a better focus. What does it even mean for me to have good mental health? What does that look like? So if I'm just sitting out there going, okay, I need to focus on my mental health. When do I know I'm there? When do I know I have a problem? Because what does it even look like to be mentally healthy?
Well, it's a challenging question because that then gets into that area that I talked about with well-being. And well-being speaks to a lot of different things in our lives. Are we enjoying our personal relationships? Are we financially stable? How are we doing? What's our mood like? Do we feel like we're flourishing at work? Are we engaged? So that's sort of one piece. Now, the mental health part, and I mean, it's this complex Venn diagram, so there aren't simple distinctions. It's not a linear, you're burned out or you have well-being and mental health is over here. It's really complicated. But what I will say is when how you feel and how you think really starts to interfere with your ability to function at work with the people that you care about, and time away, like a vacation or whatever, doesn't make it better. Because remember, when we talk about well-being in the workplace, we're trying to talk about the work factors. And then there are the personal factors, and they do interdigitate. But, if you're really feeling lousy or anxious or whatever, and you get out of the system that you're in and you feel better, then it's probably more related to the system. But if those feelings and attitudes and beliefs persist, and we like to say 2 to 4 weeks, 6 weeks, they persist over time and they continue to interfere, that's the time to get a consultation. Okay. And what I would say is if you're asking yourself the question, is something going on? Do I have depression? Am I overly anxious? Is this something that psychotherapy and or medication might help? If you're asking the question, go get the consultation. That's not going to hurt anybody. Nobody's going to commit you to doing something, but go see someone and check it out. If your back hurts and, you try the compresses and, whatever, nothing sort of works, then you go and get a consultation. Then they may just say you strained it because you used weights that were too heavy in the gym, but you go and get a consultation. But somehow people are reluctant to go and get the consultation. I also have very strong feelings that psychiatrists should be the gatekeepers here. This flies in the face of everything that's done. Why? Because I think that in our training, we learn that there are a lot of different things that cause mental health problems, some of which need more sophisticated treatment, others of which may need counseling or general support or meditation or something that a lot of other people in the mental health field could do. But I feel like you kind of need to go to the person who sees the whole gamut first, and then they can help point you in the right direction.
Chris was laughing a second ago because he knows I delayed getting my back checked out for like months and months.
I picked it, right?
And then I finally got an MRI. I was like, okay. I agree with you, though. I would say that the combination, if you have the question, why wouldn't you go seek the answer?
Right.
Well, because you're busy anyway. Or maybe you don't want to have the answer.
Right.
Maybe you kind of know, too, that something's wrong and you just don't want to actually admit it to yourself that that's you. That's the hard part. But the combination certainly is true. I would just, I've been vocal on the show before about being in therapy and I really just had to engage with a psychiatrist as well, also get medication. But the combination between the two, I think, is the most effective. So that's just my personal opinion. I want to come back just to what your talk was about. It was really impactful, and I thought there were so many great points, but you spoke about the barriers of reducing stigma in mental health and GME, and the three barriers you identified, and you actually kind of brought them up already, was anonymity, access, and availability. And so I don't know if you can speak more to how these are being tackled at the various GME institutions, or what you're seeing that has been most impactful, because there is the intertwined relationship of well-being and mental health that we're seeing talked about. So if you can just broadly or more specifically address each one of those.
Well, I'm not exactly sure what you meant by anonymity.
That was one of the points on the slides that I saw. Maintaining anonymity, in terms of helping them feel safe initially.
I can't recall exactly what the reference was to, but let me I'm going to put the anonymity question over here for a moment. But the availability and access issues, you were asking what is being done. I think, and this is my personal belief, it's not anybody else's, but I think given the peculiarities of the schedules that residents have, as an example, that the best and most effective answer to both the availability and the access is for systems of care have dedicated people, psychiatrists and psychologists, who are specifically hired to take care of the house staff. And why do I say that? Because you need people who understand that week to week their schedules are going to change. So you need people who are flexible enough to say, well, I'll see you at 2:00 on Tuesday this week, but next week I'll see you at 4:00 on Thursday, or whatever it is. And if it's built in and if the system is paying for it, then we can throw out the insurance question. Totally. We can just say, this is a cost that the system is going to take care of. And, what's the total cost? It's a couple of $100,000, for a couple of people to do it. And that would make a huge difference, because these kids, they're not going to be coming, necessarily weekly every week for time on end. I mean, mostly when I see my patients, I say, when do you want to come back, right? When's convenient? When can we schedule this? And for some people, it may be the following week. And for others, it'll be in a month. Or they'll see someone weekly for a little bit, if there's an acute issue, and then it will get stretched out. So I think having dedicated people who understand what's going on in medicine and in training is really important. The anonymity question, I think, I may be misremembering this, but what I like about anonymity is I like the idea of anonymous surveys that people can take to see how they're doing. You were asking the question of, how do people know that there's an issue? Well, there's the American Foundation for Suicide Prevention has an interactive screening program that they can work with healthcare systems to set up where they can have anonymous screening so that anybody can go on the site, take a survey, and if they score a certain whatever, then they will be connected to mental health services in their institution if they are interested in doing that. And I think it's a great way to get people over being scared about that. The other challenge, and this isn't exactly anonymity, but I'm using it loosely to get to you, is that people feel more embarrassed or more concerned, less so now, but about seeing people for treatment in their own institution, that they would rather see somebody, like if somebody at Montefiore Einstein comes, they'd rather see someone at NYU that they won't run into, that they won't see, even though they would see the orthopedist here, but somehow they're more concerned about seeing a mental health provider. I think that's getting better. I think, again, the younger generation is a little less concerned about that. And remember, if we have dedicated FTEs, full-time equivalent people hired to do this, then they won't be interacting with other people. People don't quite believe that the medical record is private, that there's, like break the glass, that it's not that anybody can see your record. I personally think it should be the same for mental health as it is for anything else in medicine. Nobody should know, Paul, about your back problem unless that should be in your record, but it's nobody else's business except yours and your doctor's. And it should be exactly the same. So as we start to reduce stigma and compare it to other medical conditions, I'm hoping that concern will be less, because I think that that my mental health should be just as private as my physical health. So I don't know if that was the anonymity part that you were getting at, but it is a concern of the house staff. I think they don't want to see people that they might run into, which is understandable.
I think that was, and I know that you had a couple of other co-presenters, so that could have been something that I pulled from maybe one of their slides, but it does speak to the idea behind not wanting to approach somebody in your institution anyway, and just the fear in general, but of maybe of being found out, and maybe the fear that we all build up in our head that I'm the only one dealing with this issue.
People feel sort of humiliated, embarrassed. I don't know, that this, because these issues affect how we feel and how we think, which are part of being human, right? How we feel and how we think is this quintessentially part of being human. They somehow feel if there's a problem here, then, it must be a moral failing. It's not something else. It's not.
Yeah, I think when you describe the back or an ortho, right thing, it's something physical, right? We can see someone limping. We can see they have a hurt shoulder. It's interesting, the fear that someone may have of that transparency of being in an organization where someone knows so much about your mental health and your well-being. You're the first person that we've talked who has separated those two very important segments, that they are two separate issues. If I ask everyone the color of blue, you're both probably going to be correct, but you may describe two. In fact, y'all are both wearing blue shirts. If I ask someone about mental health and wellness, they are describing. And when I heard you speaking a second ago, it reminded me, my wife was sitting on the board of a grief center, and it was for children who had lost their parents or loved ones. And we were helping raise some money, and we went to a family foundation, and the person said, well, it's a worthy cause, but how do we know when they're better? How do we actually measure? If I give the money, how do I know that they got better? Or is it an ongoing scenario? I still think at the great progress that you have made and your peers have made in the medical community, outside of the medical community, we're still dealing with that label of, okay, well, when are you done?
I think this goes back to, I hate to throw Freud under the bus, but this whole fantasy that people go into treatment and they're just whining and complaining and, enough already kind of thing. The reality is, I suppose, and I guess I would say this, that it helps all of us to have time to reflect on how things are doing in our lives. And if you want to look at counseling in that vein, one could say carving out an hour every week or every couple of weeks to do that is a good thing. And you could do it forever, but you don't need to do it forever. And again, I go back to the interference piece. And it's like anything else. We have to weigh risk and benefit. Can I afford this? Can I afford the money and the time? And most people don't want to do this forever, if you will. But if it's helpful and you have the time and money to do it, I guess you can do it. But you could also say that about, I'm going to go back to Paul's back injury, so he's told it's a back injury. I do want to say that you can't see it as well as you can see, somebody breaks a foot, you can see a broken foot, but pain, discomfort, you can't see that either. And, how do we decide that? And that's all based on the individual. So, does it interfere? That's a question we would ask about your back as well. If and then when is it over? And when do you stop PT or whatever? So I keep wanting to make analogies with the rest of medicine and your physical health, as it were, to say that the brain is it is another organ. We don't see it. And it's so complicated. We don't understand how it works. It's clear, you were saying, Paul, I think earlier, that, a lot of it is the medication and the therapy. And I couldn't agree with you more. And it's not true that psychiatrists just push pills. It's both, because there is physiology involved as well as psychology, if you want to look at it that way, just like it is with anything else in medicine. So my view is, yes, I don't just do meds for my patients. I'm always doing some therapy. It's a relationship that you have with someone where you're talking and someone gets to know you. And that's really important. Mm-hmm. So I'm a big proponent of the both and I've resisted and I get very upset with the attempt at dichotomization in mental health.
Well, I think you have to have both, because the medication helps for me, takes the edge.
Correct.
The stuff that's just a little too deep or too hard to deal with, so I can only tolerate so much before then I might even consciously or subconsciously just push it back down and deal with it later. And then it's going to exude itself somewhere else some other time. And so having the ability to have that edge to be able to then confront it through the therapy at the same time, because then it just feels like it's just too much to deal with in one, sitting. So I think it and then being able to go back to, like you said, being more functional at work or with family or, wherever you're interacting. So that's why I think the combination, it's just helping, do I hope to do both forever? No, I don't. But I think that there is some normalization that has occurred where I was in therapy and then I wasn't, and I was in it and then I wasn't, and then I was on medication and I wasn't. And this has been the story for years, but it's like just getting to a place and then life happens and you just get to a place and then life happens and you just try to continue to work through those things the best you can. So I wanted to share, I always bring up my daughters, by the way, Dr. Bernstein.
I do that too. It's okay.
I find a way to work them into every show. So I was talking with one of them the other day, and she had started to just kind of open up and sharing how stressful things were. And it is within this mental health issue that I think it's harder. And the old thought process of, well, fake it till you make it, or just think positive, or I don't have it as bad as somebody else. And I was thinking, and I wrote this down when I was in your session, was fake it till you make it, and try to not fake it until you break it, right? Like mentally, you just go too far and you push through. But she was just kind of opening up and sharing some things and saying, but I look at my life and I have it much better. It's not. And I said, hang on a second. The hard part here is that we don't know how to grade. If you go into the doctor's office and you had broken a finger, they're going to ask you, what is your pain? They can see it. What is your pain? 1 to 10. And you say, okay, well, it's an 8. Somebody else might come in and they had their hand chopped off, and same thing. What is your pain? 1 to 10, 8. Well, you had 2 different injuries, but you're grading it both at an 8. So now are you not really an 8 because that person had their hand chopped off? Now you're evaluating theirs against yours. You were asked what you're thinking and what you're feeling at that moment to grade how much pain mentally you were in. You said an 8 because that person shares that same number. That's their best grade. So don't deflate how you're actually feeling. And I think we can, do that all the time, where I don't have it. We unfortunately step on the backs of people that might have it actually worse, but to try to prop ourselves up when we should just sort of accept right where we're at and try to work from there.
I don't know if this was in my slides or not. It's in another set, but don't compare your insides to someone else's outsides, and I think that that's really important to just bear that in mind, that our own experience is our own experience, whatever that is. And we don't have another way to measure it. I mean, I can't know what your back pain is like compared to my back pain. I don't know that.
Mine is definitely worse. I'm kidding.
I got it.
I wanted to jump over to one of the other topics that was brought up in terms of having the support within the GME system, the program directors, the coordinators, and even the people in the GME office, and encouraging them to be available, listen to the residents, fellows. But is there proper training on that end? You talked about the generational difference in perception of mental health, and that the younger, which I can attest to too, because again, same daughter said, I don't understand why it's such a big deal for y'all to go to therapy. Everybody talks about it at my school. But if you take and you have an older physician that's in training and they're great at what they do, but are they able to really speak to it? Is there leading by example in terms of the mental health and taking care of themselves? Is there encouragement from ACGME or GME programs in general? How's that being addressed?
Well, I think that part of what has happened in GME is that the requirements. I mean, requirements are sort of a stick. We like to have a carrot too, but telling programs they have to pay attention to this is one really important thing that the ACGME has been able to do. I think the issue of what's happened with the older generation has been that this has been hidden, right? This has not been something that's been out there in front. But what's happening now too is more of the senior leadership, like Daryl Kirch talked about, that more people in senior positions are talking about their own vulnerability. I cannot tell you how critically important I think that is. And this has been sort of the shameful secret. It's not that doctors never sought mental health treatment. It's that the ones that did it all in secret. And we're trying to get people to be much more forthcoming about that. And I do want to mention, even though it's not directly related to your question, that the American Foundation for the the licensing board, the Federation of State Medical Boards, has really done a great job of proposing de-stigmatizing questions on licensure exams. A lot of states that had stigmatizing questions no longer have them. I think it's going to move dramatically. It now has to move in the credentialing and disability arena. Same thing, not stigmatizing. It doesn't mean you don't have a disability or an issue, but that, is this something that will interfere with your ability to practice medicine? That is the question that's a fair question to ask. Not, did you ever see a psychiatrist? did you ever have depression? That's not fair. They don't say, did you ever have a back injury? Well, I'm sorry, I keep going back to that. But I think, it's just, this is the same. And I think it's really important. But I do think that more of the older folks are getting better able at sharing experiences, which is, important for all the work that we do, that the older generation needs to try to mentor, if you will, the younger ones, whether it's about mental health or anything else.
Yeah, I think it's important. We do look to, especially as you're going through and you're being taught and you're mirroring back what success looked like before, right? You mentioned the application, and we've heard that from someone else that's been on the podcast about, hey, if you check that box, the concern is now you have a label on you and people may not be, move forward. Or if you say, yes, I did something here. And I was visiting with a physician who decided to leave medicine. And I was talking to her about our conversation that was coming up with you on the podcast. And I just started saying, tell me, why did you leave medicine? What was going on? And she said, I was struggling. There was a life event that happened, and I felt that I was in this depression state. And as soon as I mentioned the word depression, then I noticed that things changed within my department. And that became this weight that I couldn't break out of. And she said, I was just going through a down period. And so it's interesting you talk about, hey, if something happened for 2 weeks or 4 weeks, and the importance of having someone who understands the stresses of a resident and a fellow to be able to say, hey, I know what you're going through a stressful time. Let's talk about that. But it was interesting. I shared with her your bio a little bit and what you did. And she was pleasantly surprised. I don't want to say shocked. That's a strong word. Pleasantly surprised at how high up you are and how influential your position. Because she said, if I had not experienced that, I probably would still be in medicine. If I hadn't said the word depression when I was talking to someone, that became my label that I could never break free from. So I applaud you for making these changes. I think the patient physician, while this topic has been around for a while, it's interesting to Paul and I as we go through it, how often physicians come up and say, oh my goodness, like, how do I take care of myself? How do I take the time to be present so that I can be a better doctor? And it means different things to different people we'll get to. But thank you so much, because you peel that back, and you started with the negative events in New York in 2013. We've seen this again and again where physicians or just people in life get to a point where they're not sure that there's a solution out there. And they make permanent decisions on something that maybe if they had the opportunity to get some help along the way and not wait till things were an emergency. My oldest son's getting married in a year or so, and they were asking my advice, which they probably regretted. But I said, I'd recommend y'all get in marriage counseling now, like start counseling. And they said, no, nothing's wrong. Like, we're getting along well. And I said, that's exactly the right time to start having those conversations. Don't wait until you're about to, make horrible decisions or you've jumped off the bridge. Let's start those conversations. And so I applaud you for opening that conversation earlier in people's lives.
Yeah, well, I think, I've sort of get myself into a little bit of trouble. Suicide is a very galvanizing event when we lose someone young to suicide. I mean, if you lose anybody to suicide, it's really troubling. But it's actually, among our trainees, it's actually rare. And unfortunately, we in psychiatry don't know who is going to die by suicide when. We just don't. And it's very hard to get that message out there and to say, but as you say, there are a whole lot of other things that we can do something about. That when people are depressed, when they're stressed, when they're anxious, we can get them help and support. The likelihood of that being a terrible outcome is reduced. And sometimes, I've never, fortunately, ever felt like I really had to end it all. But sometimes what I want to say to people is, hang on. Our feelings change. They aren't this way all the time. And I think our loss of community and connection has contributed to why people feel isolated and alone when they're going through a bad period. And listen, medicine is really stressful. This is not an easy job. This is not for the faint of heart. So you should know that at the beginning. And it isn't for everybody. I will just say that it isn't. So you need to know yourself. But there are certain aspects of this work that while they're hard, that we can support each other and get through it so that people don't have to decide that they just have to leave, and that we can reduce the stigma around feeling bad so that people don't feel that that's the only choice.
We've compared physical to mental health throughout the show so far. And if I'm going to be healthy physically, then I don't wait till I'm having a triple bypass and then, start to try to eat. We really need to start eating healthier, go exercise. So why are we waiting till apparently something wrong mentally? Why can't it be part of just the normal diatribe, daily, monthly, weekly, or exercise, whatever, to go exercise that muscle of working through stressful days or topics or weeks before it's a critical mass?
Well, I think, what's important is to know yourself, right? You need to know what things make you feel better and what things really drain you. And you need to take a minute, whether it's once a day, nobody's ever going to do this, but once a week, once a month. I mean, but just to say, or like, I got up yesterday and or yesterday afternoon, I was like feeling out of sorts. And I say to myself, oh, this is just one of those days. It's just like not a good day. But by saying that and articulating it, you're going with what you're feeling. You're not trying to make it otherwise. So you're, in a sense, you're actually exerting some self-compassion. You're sort of saying to yourself, this is just a tough time. It's going to be better tomorrow. I'm going to go to bed and get up and it'll be better. And again, if it persists, continues to interfere, that's when you go and you try and seek help. But we have to really understand ourselves. That's kind of where it begins. What makes me happy, what doesn't, what makes me anxious, what doesn't. And I will say, we talk a lot about depression among house staff. Most house staff are really anxious. They're taking care of sick people. They want to do a good job, and they're really anxious about not doing a good job. But the fact that they're anxious, those are some of the reasons that get you into medicine in the first place. This compulsive triad we talked about, doubt, guilt, and an exaggerated sense of responsibility, because we do have a big responsibility. But those same characteristics can sometimes make it so that we're unduly hard on ourselves and that we don't take care of ourselves appropriately. And it's hard because it's dynamic. It's not, one day you may want to go to your, you want to be sure you get to your daughter's, ballet recital. And another day you may have a patient who's dying and or really in bad shape and you need to miss the recital to be with the patient. And it's not a profession where you can say, oh, this is it. It's a constantly changing circumstance. And that's how we feel too. That changes a lot all the time.
Well, I think the constant, even just the training alone, the constant doing for others is built in. That's what they're trained and taught, and care for others, care for others, care for others. That to be able to have someone like you and ACGME pointing it back and going, no, you need to care for yourself, and here's how, and starting to give tools and sources, making the availability, advocating for having it built into programs, I think is a great start. So where does it go from here? Where's the next biggest growth for GME programs?
Well, I'm going to be it's small, it's an anecdote, but I think it's significant. So I just finished doing a bunch of mental health check-ins for our medical interns and actually our orthopedic interns. I mean, if I think back to my training, when would an orthopedic program director say, yeah, you can go have a 30-minute check-in with a psychiatrist? Huh? Right? This is huge. So I'm seeing that the acceptance of a check-in like that this is becoming, the program directors, the coordinators, they're saying this is okay. Yeah, we can do this. You could do this during, you could take time off from your lecture. No, not when you're on night call and you have 8,000 patients to take care of. But we can figure out a way to build this in to the curriculum so we can have a checkpoint for you. That's enormous. I mean, I still can't get over it. I mean, it's like you got to be kidding me, orthopedics. And there, I have these big burly guys saying to me, I finish and I say, is there anything you'd like to ask me? I'm just doing, how are you? How are things? And one of them says, well, this issue is coming up in a week or two. And, can I reach out to you if it doesn't go well? And I say, absolutely. But this is a sea change. This is a mental sea change. And someone else saying, I started to see someone. It's really helpful. I'd really like to be able to see them more often. I'm like, you got to be kidding. So it's a little thing, but it's really going to help with the stigma. And there are ways that we can figure out to do this. Look, I was an intern a million years ago. I got depressed. I was in therapy with someone. And this was way before, I don't mean to say that the ACGME didn't help, but way back when I took my beeper and I gave it to a friend of mine and said, I'm leaving for an hour or two. Could you cover my patients? So that sense of connection and community for each other, so can we cover for each other? If I cover for you, will you cover for me? That makes a difference. And we can do, we can definitely do that. So I think as the culture starts to change, it will really make it easier for people to take the time that they need. And mind you, they don't need all the time in the world. I do want to say, we worry about the snowflakes and lack of resilience and all. I don't know, Paul, about your daughters, but sometimes I worry a little bit that anytime something hurts, people say, oh, I got to run to see the psychiatrist. Not so. Life is not always easy, right? And
I think my daughters probably think I'm the snowflake. I probably cry more than they do in the house. So,
right, good.
That's funny because it's actually true. But, when you're talking about how they're receiving it, and you talked at the top of the show about them taking care of their own mental health to then be better with patients, it feels like the comparison of having this top-notch restaurant that you want to deliver 5-star, and you've got the cooks in all these different positions taking care of, expected to give this perfect level of service, and then you never let them have a meal there. You never let them experience what it's like to be taken care of. So how do you know what eating and dining at a 5-star restaurant should look and feel like if you haven't felt being taken care of like that yourself? And so that idea, let's try to take care of the people who are taking care of us in that way. Let's demonstrate 5-star level of service for the people that are sacrificing every day. That's just kind of a simple analogy I kind of think about is if we really want to get the best out of them, then let's let them dine and, take care of them at 5-star.
Well, you also know, put on your own oxygen mask first.
Yeah.
I mean, there's no question. And I mean, people have talked endlessly about, the ROI and how do we convince the C-suite that these things are important. And I'm like, don't you think that healthcare staff feeling better, feeling good is going to translate to better care for patients? I mean, this is not rocket science. This is patently obvious. And it will reduce recidivism. It will reduce the Great Resignation. It will reduce all of that if people feel that who they are valued as people. And we will clearly do a better job of taking care of our patients if we do that. The patients are at the center, and so are we, and we become the patients too. So it's for us as well, not just.
And so you just led us into the perfect final question, which is brought up, but the name of the show is The Patient Physician. And so what does that mean to you in the context of everything we've talked about?
It means that we're human just like everybody else, fundamentally human. And with all the wonderful and difficult aspects of being human that involves, which means that we struggle just like everybody else, and we can be happy just like everybody else, and we can do a great job, and we can make mistakes. I mean, we make mistakes, and I hate to say it, but we make mistakes in medicine. We try to minimize them, obviously, but mistakes happen because, to err is human. I mean, that is who we are. And I think that that's not only an issue for ourselves, but it's an important issue for the general population to understand. Now, mind you, when we're sick, when we're struggling, we are very vulnerable, and we want to look to doctors and medicine as saviors. And we can't always do it, and we're flawed too. And that's a little bit hard to take, but it's the truth. And so I would say, yes, the doctor has paid. We become patients too. And let me tell you, as I get older, I'm very aware of all of this, although I'm very lucky because I have access to, I know who's good in medicine. I can find out who's good. I have contacts everywhere. One of the big things I do is try to get my doctor patients and my patient patients to the best doctors I can find. So they have to be healthy and doing well in order to do their jobs.
Well, I love the answer, and I love what you're doing. I think that the impact and just the daily work that you're doing and the impact that will be rippling through medicine for years, for generations, in terms of how it's approached and walked out. And I hope that message continues to destigmatize it out there, that they can feel better about taking care of themselves. So, Dr. Bernstein, thank you again for your time. Thank you for what you're doing, and loved having you on the show.
Well, thank you, and thank you for focusing on this. It's so important. I really appreciate it. Many thanks to both of you.
Thank you, Dr. Bernstein. We appreciate it.
This conversation was brought to you by Physicians Resource Services, a firm supporting medical professionals to improve their financial situation and pursue their personal and professional goals. The Patient Physician is produced in Austin, Texas. Editing and sound design are in the hands of the PodConnects Podcast Network. Please email questions or show ideas to info@physiciansrs.com.